usually under 2 years of age. But potentially quite a serious condition. I mean, in very simple terms, I think of this as a form of childhood pneumonia, really. So acute chest infections, for most of us, inconvenient, you don't feel very well, but recovery should be complete. Now what I want to focus on this talk really is the chronic airways diseases. Chronic bronchitis, chronic emphysema, what we tend to call chronic obstructive airways diseases. Now bronchitis is literally inflammation of the bronchial passages, and emphysema is destruction of the alveoli. And these two usually go together. In fact, you could say they always go together to some degree. So bronchitis and emphysema. We call these chronic obstructive airways diseases. Not a particularly good term, really. The best term really is chronic bronchitis and emphysema. That describes what it is. So various, let's look at the notes. Chronic bronchitis and emphysema. Now, I've heard these called chronic obstructive airways diseases, which is the term I must say I do tend to use. I've also heard them chronic obstructive pulmonary disease, COPDs. I'm not quite sure what the difference is. No one's ever explained it to me satisfactorily. And I've heard them called cold, chronic obstructive lung disease. So take your pick. But the best term really, chronic bronchitis and emphysema. It describes quite precisely what we're talking about. And in a patient with the chronic airways disease, both conditions, that is bronchitis and emphysema, coexist in each patient to various degrees. Now some patients might be primarily bronchitic, others might be primarily emphysematous, but they'll both have some bronchitis and emphysema if they've got one. And this results in airflow limitation. That's the key thing. Airflow in and out of the lung becomes limited. Now, of course, there are other conditions in which this occurs. For example, asthma. I've actually used the term AOAD here. I don't really think many people use this. I've made it up, I think. But it stands for acute obstructive airways disease, because that explains what asthma is. It is an acute obstructive airways disease. So in asthma, there's obstruction to the airway, because in asthma, you might remember, the main features are you get bronchoconstriction, the bronchioles get smaller, so less air can get in and out of the lungs. You get inflammation, so that swells the inside of the air passages, and you also get excessive secretions, which tends to clog them up a bit. So you certainly get airflow restriction in asthma. In fact, to a life-threatening degree, you can get it. But it's acute, it's an acute obstructive airways disease, and it's reversible. Whereas with the chronic one, there's damage to the lungs and the condition is there all the time to a varying degree. But with chronic obstructive airways diseases, you can get acute exacerbations. So very often in hospital, someone will be admitted with chronic bronchitis and emphysema with an acute exacerbation of the condition. This means that yes, they have chronic bronchitis and emphysema, but they've had a bacterial infection which is overlaid on that and can make them quite ill. So we're talking about chronic, not acute, obstructive airways disease. Let's define our terms. It's always useful to do that. Bronchitis, what we mean by bronchitis is a productive cough on most days for 3 months of the year for more than 1 year. So if for 2 years running, for at least 3 months of that year, someone has a productive cough, then that is chronic bronchitis. So the definition is a symptomatic one, really. It's describing the amount of cough, the amount of product produced, and the amount of time the cough is suffered from. Emphysema, on the other hand, has a more pathological diagnosis, definition rather. It's abnormal permanent enlargement of the air spaces. Abnormal permanent enlargement of the air spaces due to destruction of the alveolar wall. Let's have a look at a few diagrams and try and explain what we mean now by the term emphysema. Now here we see some normal alveoli, the air sacs, where gaseous exchange takes place, and the respiratory bronchioles. And of course the key thing is that the alveoli are infolded sacs, and this gives a large surface area over which gaseous exchange can take place. But if there's a loss in the air sacs due to destruction of the alveolar walls, then I think you can see that here there is less surface area than here. And if this happened again to another one, imagine another air sac there, and this wall was lost as well, then we've got even less surface area. So we're getting, as we said, abnormal but permanent enlargements of the air spaces, reducing the surface area over which gaseous exchange can occur. So in a normal lung section, which we've looked at in other videos and we'll probably look at again later on this one, we see lots of alveoli. If you section a lung microscopically, magnified by 500 or 600 times, you'll see that there's lots of air spaces here, and in these walls there'll be capillaries to facilitate gaseous exchange. So you have a large, spongy, elastic lung. But in the emphysematous section, then the alveoli is lost, the surface area is lost, the elasticity is lost, and of course the whole ability of the lung to carry out gaseous exchange is reduced. So here we see an emphysematous section of lung, and what we can actually see here is we can actually see air spaces. These are gaps with just air in them. And here on a macroscopic level. Now you certainly should be able to see air spaces in the lung, but only when you magnified it by about 500 times. So there's actually a lot of space here in the lung that shouldn't be here. Massive reduction in the surface area due to this enlargement of the air spaces due to destruction of the alveolar wall. And here we can see all this lung is very emphysematous. You can actually see the air spaces quite clearly. The normal lung, you couldn't see them without magnifying it several hundred times. So here we see another emphysematous lung. Large air spaces. And as we look down on this section specimen, then I think you can see here that the air spaces have become absolutely huge. Very, very severe emphysema, extending all over the bottom of the lung. So literally big caverns in the lung here, with complete loss of alveoli. So we've considered the nature of emphysema. Let's now consider the nature of bronchitis. Now in bronchitis there's infection and inflammation in the bronchial trees, in the bronchial passages. This has an inflammatory response, and it means that if this happens repeatedly and there's repeated inflammation and resolution, then you start to get fibrosis and scar tissue and thickening of the lining of the bronchial passages. And it's this which gives rise to the restricted amount of air that can get in and out of the bronchial passages. And this can become very severe, almost completely obstructing some bronchial tubes. So let's think about a normal bronchial passage first, looking at insection. And the key thing to notice is the lumen in the middle. That's all this space in here. All this is